Hello, and welcome to what I think you'll find to be a very interesting and informative session on the use of drug-coated balloons to treat AV fistulae. We are being joined today by two of the luminaries in the area of AV access intervention, and I'd like to introduce them here. But first, I'm Bart Dolmatch at the Palo Alto Medical Foundation, and the two guest presenters today are Dr. Andrew Holden, Associate Professor and Director of Interventional Radiology at the Auckland Hospital in New Zealand, and Dr. Robert Lookstein, Professor of Radiology and Surgery at the Icahn School of Medicine at Mount Sinai in New York. Faculty disclosures are here. I'll give you just a moment to look, and then we'll go ahead with the program information saying that this session is provided by North American Center for Continuing Medical Education, an HMP company, and supported by an educational grant from Medtronic. There are some learning objectives, and the first one is to understand new data and clinical findings regarding the use of drug-coated balloons in AV access, and to apply the data and findings to practice to reduce the rate of AV access intervention. Secondly, we're going to recognize when a patient with a failing AV fistula could benefit from use of a drug-coated balloon technology, and how to utilize techniques such as vessel prep to optimize results. And finally, the hope is that you will understand the risks and rewards associated with Paclitaxel-coated technology in patients with failing AV fistulae. And now I'd like to reintroduce Dr. Robert Lookstein on behalf of the IN.PACT AV Access investigators, recently publishing the use of drug-coated balloons for dysfunctional dialysis arteriovenous fistulae in the New England Journal of Medicine. And I'll turn things over to Dr. Lookstein.
Bart, thank you so much. It's really my great pleasure to be here and to share the data from this publication. I was honored to work on this trial to serve as co-principal investigator with Andrew Holden, who's also on faculty tonight. And again, it's just a great honor to present this on behalf of the entire IN.PACT AV investigative team. So in this randomized trial, patients that underwent hemodialysis that had a native upper extremity arteriovenous fistula were randomized to either receive a drug-coated balloon, specifically the IN.PACT AV Access balloon, or to undergo standard balloon angioplasty after initial vessel preparation with a high-pressure balloon angioplasty. The primary effectiveness endpoint of this study was target lesion primary patency at 6-month follow-up. The primary safety endpoint for this study was freedom from serious adverse events involving the AV access circuit itself. And the conclusions of the study were that the drug-coated balloon was superior to the standard balloon in terms of efficacy and was non-inferior with respect to access circuit-related serious adverse events. This is the enrollment chart. As you can see, we screened nearly 500 patients to randomize 330 patients. Ultimately, 170 patients were assigned and randomized to receive treatment with the drug-coated balloon, and 160 patients were randomized to receive treatment with the standard balloon. The safety endpoint at 30 days included 166 patients in the drug-coated balloon portion of the trial and 158 patients in the standard balloon portion of the trial. And then you can see how patients were excluded in terms of follow-up. This 6-month presentation of the data, publication of the data, included 152 patients in the experimental group, where the primary effectiveness endpoint was able to be evaluated, and 148 patients in the control arm of the trial. Here are the demographics. You can see that it's a relatively mature population. There were no significant differences. Approximately 2/3 of the cohort were male. Just under 10% were Hispanic and Latino. And I think all the appropriate racial and ethnic groups were well represented in this trial without a significant difference between the experimental group and the control group. In terms of medical demographics, you can see high prevalence of hypertension, dyslipidemia, diabetes, and obviously renal insufficiency, which is very characteristic for an end-stage renal cohort. With regard to the primary efficacy endpoint for the target lesion primary patency, target lesion primary patency was seen in 82.2% of those patients in the drug-coated balloon cohort, as compared to 59.5% of the patients in the standard balloon cohort. This represents an absolute difference of 22.8%, a highly statistically significant result. When you look at the serious adverse events, the primary safety endpoint for this trial, there was no statistical difference between the two groups whatsoever, thus meeting the non-inferiority portion of the safety endpoint for the trial. If you move farther down on the table, the number of interventions required to maintain target lesion primary patency was 40 for the patients treated with the drug-coated balloon, and was 91 in patients treated with standard balloon angioplasty. This represents a 56% reduction in the number of reinterventions needed to maintain primary patency of the target lesion. Again, a highly statistically significant result. In terms of the access circuit primary patency, another secondary endpoint included in this trial, the access circuit patency was seen in 73% of the cohort, as compared to 48% in the control arm, representing an absolute difference of 25% between the two groups. Again, a highly statistically significant result. Again, if you look at the sensitivity analyses for the primary effectiveness endpoint, even in the worst case analysis, this still represented a highly statistically significant result, benefiting the drug-coated balloon arm. And again, in terms of the safety analysis, again, no difference between the two groups studied whatsoever. In terms of the Kaplan-Meier analysis, again, you see a separation of the curves very early on in this trial, as early as 120 days, and the curves continue to separate out to 180 and even 210 days, which was the 6-month follow-up window included in this trial. Again, in the lower portion of the graph, the access circuit primary patency, again, statistically significant differences in terms of the access circuit primary patency seen early on, as early as 120 days. The curves continue to diverge out to 180 and then ultimately at 210 days. Again, highly statistically significant differences in terms of the outcomes favoring drug-coated balloon. So to conclude, drug-coated balloon angioplasty was superior to standard angioplasty for the treatment of stenotic lesions in dysfunctional hemodialysis arteriovenous fistulas during the 6-month follow-up window, and was non-inferior with respect to access circuit-related serious adverse events out to 30-day follow-up. Thank you very much. Bart, I'm going to turn it back to you.
Terrific presentation, Rob. Thank you so much. I will lead a brief question period here as a discussant. First off, compelling results, not only at the treatment site, but also for the access circuit, which is just so important for the patient and the payer. It's great to see that there's a technology that can really extend out the patency like this and reduce interventions. A couple of questions for you about the patients who were enrolled. Can you comment a little bit? I saw that just slightly more than a third of the patients were, I think, Asian. And I know that one of the co-principal investigators was from Japan. Do you want to comment at all about the impact of that cohort in the entire study population, vessel size, type of fistula, anything that you think might be of importance regarding the demographics?
Absolutely. Thank you for the question, Bart. This was a true global trial. This was performed at multiple sites in the US, in Japan, and in New Zealand. And the purpose was to try and create a very diverse cohort with respect to the demographic. With respect to the types of arteriovenous fistulas, I believe that Andrew's going to present data on this shortly, but there was a very significant prevalence of radiocephalic fistulas or forearm fistulas, as well as upper arm fistulas. One of the things that I think we were most proud about in terms of the enrollment for this trial is that the majority of the patients that were enrolled had fistulas that had been in use for multiple years. So these were very mature fistulas, regardless of their location, and it led us to be able to enroll a very homogeneous cohort to try and determine whether or not there was truly an effect of this particular drug-coated balloon. And obviously, we feel that the trial was successful in proving that benefit.
That's great, Rob. Thanks. Another question for you. You alluded to it, but could you talk about percentage of the stenoses that were considered the treatment site that were de novo stenoses versus recurrent?
Absolutely. So again, the cohort that was enrolled as part of this trial were patients that had been on hemodialysis for several years with very mature fistulas, patients that had undergone previous stent implantations or had recent thromboses were excluded. As a result, because we had very mature fistulas that had been in use for a very long period of time, 70% of the lesions that were enrolled and ultimately randomized were restenotic lesions. Conversely, 30% of the lesions that were enrolled and ultimately randomized were de novo lesions. Again, that it should be used when you're interpreting the data. But again, I think the major benefit here is that we were able to enroll a specific cohort with very mature fistulas that had been on hemodialysis for a long period of time.
And so you said 70% of the stenoses that were treated were
restenotic lesions.
Yeah. Did you look at all at the length of time between interventions using plain balloons historically going back versus the length of time with drug-coated balloons?
That was not a specific variable that we chose to study as part of this trial, but I certainly think that it is worth looking at in the future, and it's one of the variables that we hope to capture in the post-market global registry.
Great, and just one final question. The 6-month time point, was it a time point or a time period? How was the actual?
It was a time period, so patients were allowed to be seen for follow-up and undergo duplex ultrasound surveillance up to 30 days after the 6-month time frame, and that would count towards the 6-month follow-up window, which is why the 210-day follow-up is included within this publication. So a patient that showed up at 205 days would be counted towards this 6-month follow-up window.
Great. Thanks so much for answering those questions. We're going to move ahead now to the next slide, please, and reintroducing Dr. Andrew Holden, who will tell us about some technical tips and tricks for utilizing drug-coated balloons for dialysis patients. Andrew?
Thanks very much, Bart, and I'd reiterate Rob's comments that it's certainly a privilege to be part of the team involved in performing this impressive trial, and also great to be part of this session. Well, I'm going to discuss really how do I believe the Lutonix IDE randomized trial achieved such great results. And you can see a comparison of the 12-month target lesion primary patency between the two large randomized controlled trials, the IN.PACT AV Access trial, a 330 subject trial, and the Lutonix AV IDE trial, a 285 subject trial. Both are randomized and in trial design very similar, but you'll see, in fact, very different results. As we know, and as Rob shared, the primary efficacy endpoint for the first time in any drug-coated balloon randomized trial was met at the 6-month or 210-day endpoint. But also you can see in a Kaplan-Meier curve for the IN.PACT trial, a much pleasing and unexpected durability of result with a tremendous primary patency of 65.3% for the study or drug-coated balloon arm compared to an impressive 46.3% in the control or standard PTA arm. You can see a very different Kaplan-Meier plot for the Lutonix IDE trial. Not only are the patencies not as good in either arm, but the separation between the arms is also not nearly as impressive and certainly doesn't reach statistical significance at multiple time points. So one of the things we've got to ask ourselves is why did the IN.PACT AV trial achieve such good results, and how can we incorporate that into our current practice? We can say this significant patency advantage of the IN.PACT IDE trial drug-coated balloon arm was certainly superior to the drug-coated balloon arm of the Lutonix trial, But interestingly, the standard PTA arm of the IN.PACT AV Access trial showed a similar patency to the drug-coated arm of the Lutonix trial. So you can see, once again, if we make those points, that you can see the 46.3% primary patency for the control arm or standard PTA at 12 months in the Medtronic IN.PACT trial, compared to a 43.8% for the drug-coated balloon arm of Lutonix IDE trial. And it's fair to say that the Lutonix trial that was performed first generated a lot of key learning points, as a pioneering trial always would do. And I'd like to acknowledge Scott Treratola and the team involved in the trial for sharing some of those learnings, so that Rob and I and the rest of the team involved in planning this trial learnt some of those room for improvement, and particularly in terms of vessel preparation and how to approach stenosis at various places in the AV access circuit. I think the areas of learning and the areas we really should be focusing on are how to optimize vessel preparation, and it would appear that we were able to do a better job with that given the learnings that we'd taken from previous trials, how to optimize the use of the drug-coated balloon, and any specific considerations in various anatomic locations. In terms of optimizing vessel preparation, interestingly, in both randomized controlled trials, the vessel preparation was very similar, with pre-dilatation with a high-pressure balloon to achieve a residual stenosis of less than 30% diameter loss and avoid a flow-limiting dissection. With adequate vessel preparation, patients were then entered into the trial randomized to a drug-coated balloon or a plain balloon. But we certainly learnt that careful sizing of the high-pressure balloon versus via quantitative vessel analysis was very important to achieve at least one-to-one sizing of the high-pressure balloon to the adjacent normal vessel segment, not things like areas of post-stenotic dilatation, and to have the high-pressure balloon inflated for at least 2 minutes. So here you can see quantitative vessel analysis performed in a trial patient, where you can see two tandem stenoses. These were allowed in the trial as long as the overall length of stenotic disease was less than 10 centimeters and the stenoses were less than 3 centimeters apart. But you can see sizing with QVA is challenging here, because you can see an area of post-stenotic dilatation distal to the second stenosis, and it'd be important not to size the high-pressure balloon to that area, rather than size it accurately to the segment of vessel between the two stenoses in this particular case. So here's another example where we use quantitative vessel analysis and assess the stenosis in the venous outflow to be the target vessel to be 6.0 millimeters. But we used a high-pressure balloon, and it was clear with image overlay that we had undersized the balloon, and you can see we had a residual stenosis. The important thing here is not to stop with that vessel preparation. We then upsized with a second high-pressure balloon, this time at 7 millimeters. We took that out actually to 7.0, but we're prepared to just slightly over-dilate the drug-coated balloon to maximize balloon wall contact, and we believe that is an important part of the adequate trial treatment. And you can see our final result was much better without a residual stenosis. So vessel preparation and good technique is very important. You can see with the semi-compliance or degree of ability to change diameter with the balloons that we have in the IN.PACT AV Access trial that you can really optimize balloon dilatation to maintain vessel wall contact. It's also very important that we overlap the target lesion zone by 1 centimeter either side of the vessel that came in contact with the high pressure balloon with the drug-coated balloon to prevent edge restenosis. We mentioned specific anatomic locations that were included in the trial, and also the fact that 70% of the lesions in both arms were restenotic. The locations were divided by the angiographic core lab into 6 different locations. You can see most of the lesions were at the anastomosis, in the venous outflow, or in the cephalic arch, but the distribution was not different between the 2 treatment arms. We can also see when we look at the results of this trial that the patency advantage favored drug-coated balloon at all of these locations. And while we often think of the anastomosis and the cephalic arch as being particularly challenging locations, actually these performed better than other sites, but all showed a patency advantage for patients treated with the drug-coated balloon compared to standard PTA. So I think there are some challenging locations such as the cephalic arch and anastomosis, which require specific consideration and preparation as we have just discussed, but with careful technique, excellent results can be obtained. Thanks, and over to you, Bart.
Thanks so much, Andrew. Lovely presentation. I have a few questions for you. I think you alluded to the fact that you learned a lot from a previous drug-coated balloon trial. Could you enumerate any of the specifics that you learned from that trial that are real take-home points for people who might be using drug-coated balloons?
Well, it's fair to say, and thanks for the question, Bart, that, in terms of the inclusion criteria, as Rob had mentioned, we excluded patients, for example, that had previous access circuit thrombosis and it had stents in the AV access. That was a little different to the Lutonix trial, so we'd learnt some important lessons there. In terms of vessel preparation, one of the things we felt we learnt the most was the issues of careful balloon sizing. As I showed in one case, there was a preparedness, and we encouraged investigators that QVA, although it's the best tool we often have, outside of things such as IVUS or OCT to accurately measure target vessel size, it still has some limitations. And there are a group of cases where you've ended up undersizing your high-pressure balloon. We really encouraged that investigators were prepared to open the most appropriately sized high-pressure balloon and optimize the results, and actually have a very critical look at the post-angioplasty results to try and see if we got a residual stenosis less than 30%. That said, when we analysed the results with an independent core lab, in fact, in both arms there was a percentage of patients who still had a residual stenosis of greater than 30%, and that's just operators tending to think their results are better than the core lab adjudicates. But the drug-coated balloon managed to still outperform conventional angioplasty in that group.
Let me ask you about the absolute sizing. It looks like you're pretty close to one-to-one sizing, and I think there are a lot of operators who actually pick a larger balloon, so they might be 1.2, 1.3 times the size of what they consider to be the normal reference vessel. Going too far to dilate that big?
No, Bart, another great question, and it's fair to say that this is really where the discussions with investigators was important. So the careful trial design was one-to-one pre-dilatation. We encouraged that, but we would encourage clinicians to slightly over-dilate with the drug-coated balloon. So while that's not formal protocol, that was something that we developed and encouraged clinicians to get that 1.1 to 1.2 to 1 dilatation with the DCB. Not only optimizes angioplasty, as you suggested, Bart, but it maintains drug-coated balloon wall contact to optimize drug delivery and the anti-restenotic effect.
Okay. Do you think we should, in the event that we're using plain old balloon angioplasty, be always dilating for at least 2 minutes?
Yeah, I think one of the things that drug-coated technology in all applications has taught us is that we perhaps, in retrospect, got a little bit loose with our plain angioplasty technique. And there's no doubt that with careful technique, as we've seen in this trial, we can improve the results of plain angioplasty. And I think duration of angioplasty time, as well as the rate of inflation, slower inflation and slower deflation, those are all important techniques, I think, to optimize the angioplasty result.
And was the angioplasty, the vessel prep, a 2-minute dilation only once, or was it done a second time or a third time? What was the formula?
So we limited that. We did require a minimum of 2 minutes, but certainly interventionists could make that decision if they felt the balloon was appropriately sized, but that after 2 minutes they felt that there was a significant residual stenosis. They were welcome to use their clinical judgment and prepare the vessel as well as they possibly could. We're really asked that we created a minimum inflation time, but ask the sites to optimize vessel preparation.
And one final technical question. Let's say that there's a suitable stenosis. The operator plans to use a drug-coated balloon, finds a very difficult stenosis to dilate, but goes with ultra-high pressure, and there's a local extravasation. Nothing catastrophic, but you can see that there's some extravasation beyond the margin of the vessel wall. Is that a suitable condition where you'd use a drug-coated balloon?
I think it comes down to grades of extravasation, Bart. As you know, in our clinical experience, it's not an uncommon thing to see very minor extravasation. Obviously, if there was significant dissection or rupture, that those cases were clearly excluded as per the protocol. But as you and I both know, quite often after optimum sizing, you may see some subintimal contrast, and I think that's not something that would detract me from using a drug-coated balloon.
Great. Well, thank you so much. Great answers. We're going to move ahead to a topic that's been very hot and remained hot over the last couple of years. Rob Lookstein is going to talk about mortality risk for paclitaxel devices vis-a-vis use of drug-coated balloon technology with paclitaxel in the AV access circuit. Rob?
Thank you, Bart, so much. I couldn't agree more. This is a very important topic that we've all been looking at for it seems like forever, but it's been just under 2 years now. So I'm happy to share with you what I consider to be the latest developments in this. I think we're all familiar with the fact that there was a meta-analysis published in late 2018 that implied that there were several papers with long-term follow-up demonstrating a higher mortality risk for patients treated with drug-coated balloons as compared to plain balloon angioplasty in the superficial femoral artery. So these are 3 trials that were not subjected to meta-analysis, but where the sponsors looked at patient-level data, where they went back into all the individual patient charts, tried to get as much comprehensive follow-up as they possibly could to try and really discern within the confines of these individual trials whether or not there was a mortality signal. So here you have 5-year data for IN.PACT Admiral DCB in the SFA. You have 5-year data for Zilver PTX, which was the first drug-eluting stent trial in the SFA. And you have 3-year data for the StellarX drug-coated balloon. And while there's a small trend in IN.PACT AV Access, and maybe a small trend in Zilver PTX, these are not statistically significant trends at all. In StellarX DCB at 3-year follow-up, there's arguably no difference whatsoever. So it really calls into question whether or not the meta-analysis truly has validity and so truly holds water. So that's my first introduction, is that there's been a lot of question about whether or not the initial meta-analysis is still relevant now in 2020. There's a number of subsequent meta-analyses that have happened that really call into question the so-called hazard ratio, or the increased mortality risk. The first line here onto the left is the original article in the Journal of the American Heart Association, which inferred that there was a 1.93 hazard ratio with more mortality for drug-coated balloons as compared to plain balloon angioplasty. A independent group, the Viva Physicians Group, hired an independent statistical team just with the data that they had available using similar methodologies. They were able to bring the hazard ratio down to 1.27, and the confidence intervals nearly crossed the line of unity, really calling into question the original findings of the meta-analysis, again, published 2 years ago now. Subsequent to that, we've had a series of observational publications publicly presented, several in the peer-reviewed literature, including the VQI data set, which is multiple specialties supplying prospective data from North America, which seems to imply a mortality benefit for drug-coated balloons. We have private payer data set, the Optimum data. We have the Medicare inpatient data, looking at drug-coated balloons, the Medicare data looking at drug-eluting stents, Medicare low-risk cohorts. None of these seem to imply that there's a mortality signal at all with the use of peripheral drug-coated balloons. And I think as we're starting to expand this even into sites outside the United States, large European payer claims data, it really calls into question whether or not the original findings of the meta-analysis, again, are relevant in this modern era. So the United States Food and Drug Administration held a panel as part of its circulatory system devices group in about a year ago now, in June of 2019. And while they certainly felt that there should be a different informed consent for the use of paclitaxel-based devices in the superficial femoral artery, they also said that it's appropriate to use these devices for other indications, including arteriovenous fistulas. And they noted that there has not been any signal to date that says that there is concern about mortality in these other anatomic regions at all. It also noted that the benefit risk profile for these patients are likely going to be very, very different than what was observed in the previous SFA, so-called claudication trials. Other vascular beds that have been studied are the below-knee circulation, and here you have 5-year follow-up from a coronary drug-eluting stent that elutes paclitaxel, the so-called PATI trial, showing no difference in mortality at 5-year follow-up. You have the first long-term follow-up from a paclitaxel-coated balloon, the IN.PACT DEEP trial, with no difference in survival at 5-year follow-up for that trial either. And then the most recent submission to the U.S. Food and Drug Administration, the Anatomic DCB BTK trial, which now has survival data out to 36-month follow-up, and again, no difference in mortality whatsoever in that trial as well. So again, we have 3 below-knee trials that show no difference in mortality benefit, again, calling into question this overarching concern about paclitaxel use in the peripheral circulation. If you look at the baseline mortality rates of all patients in the United States on hemodialysis, it's unfortunately strikingly high. The most recent look at claims data from an epidemiologic perspective shows that unfortunately 1 in 3 patients who are on hemodialysis will not be alive at a 2-year follow-up period. And it's difficult to put the previously seen rates of mortality for peripheral arterial disease into this context. It's truly apples and oranges. They are different demographics, and it's really difficult to translate the risk-benefit ratio for these 2 different cohorts. This recent publication from, again, our co-faculty, Andrew Holden and Ramon Varco, looked at a meta-analysis of all published literature looking at paclitaxel-based devices in dialysis accesses. And this recent publication, published late last year, found no difference in both short and midterm mortality among patients who were treated with a drug-coated balloon as compared to patients treated with a standard balloon angioplasty. And the proven benefit, at least preliminarily seen for drug-coated balloons without any evidence of harm, seems to suggest that this is a technology with really tremendous opportunities to improve the quality of life for the end-stage renal population. What we have so far in terms of the published literature, we have 12-month follow-up from IN.PACT AV Access, the trial that we're discussing this evening. And so far for IN.PACT AV Access at 12 months, there's no difference in mortality whatsoever, no separation of the curves at all. We have nearly 2-year follow-up in the Lutonix AV group. And while there is a very, very subtle trend with separation of the curves at 2-year follow-up, this is not a statistically significant difference between the 2 cohorts. Both of the trials, as per the US FDA recommendations, are following their cohorts for 5 years. So obviously more to come, but there's no safety concern as of today. So to conclude, after a single meta-analysis published almost 2 years ago looked at paclitaxel use in the femoral arteries, raising a theoretical concern about a potential mortality risk, there have been numerous contradictory meta-analyses and subsequent reports demonstrating that there's clearly clinical benefit and likely safety of peripheral paclitaxel use, not only in the superficial femoral artery, but in other vascular beds. This remains, unfortunately, a controversial issue, but to date, there's no data demonstrating a safety signal or concern for paclitaxel use in AV access. And obviously now we have data that shows a clear, compelling clinical benefit. Thank you very much. And again, Bart, I'm going to hand it back to you.
Great, thanks, Rob. Hey, a quick question about the Katsanos publication. So why do you think that meta-analysis saw this mortality signal at 2 years and beyond? I mean, it seems like nothing else has really substantiated that so far. Of course, we're waiting for more data beyond, a year or 2 or 3. But what do you think? Why did?
Yeah, so I think the best theory about why that publication made that observation, and this is not my theory. I think Andrew actually was the first person to really intelligently verbalize this theory. It really goes to the fact that the follow-up between the two cohorts after 2 years was largely discordant. There was significant ascertainment bias in terms of the compliance of the patients at follow-up, the level of medical care the patients got at follow-up, and that led to these observations in the initial publications, which lended themselves to a controversial methodology for the original meta-analysis to suggest that there's a mortality signal. Subsequently, as there has been much more compulsive follow-up, largely funded by the original sponsors, so that now that we have follow-up in the ranges of 95% for each of these individual trials, these trends that we're seeing in the mortality difference almost go away completely. And again, now we have the StellarX trial, which has published no mortality difference at 3 years and has presented no mortality difference at 4 years, clearly showing that there's not a class effect. And so I really believe this was, unfortunately, poor trial follow-up and bad ascertainment bias in the original trial designs and methodologies. And I think we're just catching up with it now.
Really, very quickly, let me just ask both of you. Let's start with Andrew. When you use a drug-coated balloon, do you consent patients differently than if you were just consenting them for the procedure? Recognizing that I think many people were concerned about consenting for subsequent problems potentially with paclitaxel, where we really typically just consent people for the procedure. How do you handle your consent for use of drug-coated balloons?
Thanks, Bart. I think the answer really depends on the geographic location that you work in and perhaps also the medico-legal environment. But here in New Zealand, I think as Rob provided a fantastic summary of and I totally agree with his answer as to why we saw the results that were initially published in that meta-analysis. I think it's become clearer and clearer that was really a function of trials not planned or sized for mortality and susceptible to biases such as ascertainment bias. And so I don't routinely discuss with our patients who are having a paclitaxel-eluting device the issue of mortality. I'm happy to discuss that should patients raise that as an issue, but they don't routinely do that. But we do not currently have mortality in the patient information sheet and consent form here in New Zealand. I think that will vary depending on the medico-legal environment. I think even in that situation, such is the powerful effect of improved patency and durability. And we also know the morbidity associated with re-intervention is such a tough thing that most patients, when presented with the durability and freedom from re-intervention results, opt for a drug-eluting technology.
And Rob, how do you consent your patients?
So if we're talking about purely AV access, I firmly believe there's no published data at present that suggests that there's any mortality signal or any concern for harm in this population. And so I do not discuss it. I have a very different workflow for my patients who I'm treating femoral artery disease, as is recommended by the US FDA. But as I just presented on, there is no data to date suggesting that there's any concern regarding mortality for drug-coated balloon use in AV fistulas, and I do not discuss it as such with my dialysis patients.
Thank you so much. We're going to move ahead to the fourth and final topic of this presentation. It's going to be about the use of drug-coated balloons in AV fistulae, putting the data in context. Will this change my practice? By Andrew Holden. Andrew?
Thanks, Bart. And yeah, this is obviously some opinion-based presentation, but I think it's important to look at this powerful data that Rob presented, the Kaplan-Meier analysis of the primary endpoint, and to get a primary patency of 81.4% at 210 days or 86.1 at 180 days is really a staggering result, as well as the difference between the drug-coated balloon and plain balloon arms. Importantly, and rather pleasingly, as you mentioned, Bart, for the patient perspective, not only do we see this improved result in terms of efficacy at the target lesion, but the entire access circuit patency results are very pleasing, and the difference between a primary drug-coated balloon and a standard PTA approach is really very compelling. When we have a look at the subgroup analysis, and this was touched on, you can see that if we deal with de novo, which represented around 30% of the patients in both arms, and restenotic around 70%, you can see that in both groups, drug-coated balloons perform better than PTA, but particularly the restenotic group, which of course the vast majority of patients fall into this group. We also look at AVF type, that is forearm or upper arm, and as you can see, the outcomes in both the forearm or radiocephalic AV fistula and upper arm or brachiocephalic and brachiobasilic AV fistula also favor a primary drug-coated balloon approach compared to conventional or standard PTA. When we then have a look at the anatomic locations, as we've previously seen, all the locations appear to do better with drug-coated balloon, but if we highlight some, then particularly the anastomosis and the cephalic arch, which are often very problematic lesion locations. And we spent a bit of time trying to figure out why we see quite a difference in outcomes between the two randomized controlled trials that really had a very similar trial design in terms of patient selection and vessel preparation, one that clearly met its primary efficacy endpoint and one that didn't. We've seen the two drug-coated balloon trials put in comparison. Let's have a look at some of the other treatment strategies. So just to remind you, if we look at Rob as the PI of the IN.PACT AV Access trial, we can see that a primary patency at 6 months of 81.4% and at 12 months of 65.3%. You can see in yellow the inferior results seen with the Lutonix AV trial. If we have a look at some of the best stent trials in AV access, you can see that 6 and 12-month results are much, much poorer. And if we have a look at Bart as the PI of the Covera trial that's recently been presented, very impressive results indeed with a stent graft. But you can see, and although there are some issues with comparing trials directly, very similar 6 and 12-month patencies between these two trials. Of course, the drug-coated balloon trial has a leave nothing behind approach. So how does this data influence my clinical practice? Well, I think we can see that the patency advantage of high-pressure balloon preparation followed by drug-coated balloon angioplasty was seen across all AV access types, lesion types, and lesion locations. And therefore, I believe it's reasonable to use a primary drug-coated balloon approach to all AV access circuit lesion interventions. We've now seen not only 6-month efficacy and results, but 12-month durable results without a safety concern, as Rob presented. And we are also getting some data led by Rob and the team on the fact that this may be not only efficacious, but highly cost effective. And that's something perhaps we could discuss further. Over to you, Bart.
Thank you, Andrew. And that's a great segue into talking about the practical use of drug-coated balloons. And it brings up the question of cost effectiveness and cost to the center. I think there are different ways, certainly we've looked at this. I published on it for covered stents. I know Rob has been looking at this, and maybe you too, Andrew, on the cost and the financial benefits to the payer and the center and so forth. But let me ask you this. Throw out a hypothetical. What would you tell the physician owner of an outpatient lab about the cost effectiveness of drug-coated balloons for using them for every lesion? I mean, it seems like many of these outpatient labs run on very thin margins, and I don't know that the reimbursement is quite there yet for the drug-coated balloons. Do you have any comments?
Well, I think I'll get Rob to make some specific comments, particularly around the US outpatient market. We're obviously far more familiar than I am, but primarily, I think there are two things. One is reimbursement and the size of the upfront cost of a drug-coated balloon. That's obviously going to be differing in various geographies, but to be important. But the second thing is, of course, the driver for freedom from reintervention. And so the more powerful the patency difference and the freedom from clinically driven reintervention, the more likely that this treatment will be cost effective. Not only that, it's going to be cost effective the further you go out past the index procedure. And if we think of not only a patient basis, but a health system or even country basis, this would have the potential to save huge health dollars. And perhaps I might get Rob to be more specific in his answer.
Sure. So thank you, Andrew. It depends on what kind of model that you're working in, Bart. And I think that you would be the first to agree that there is tremendous heterogeneity in the practice models that we're seeing right now in North America. We have fee-for-service models, we have shared savings models, we have capitated models. And in a strictly fee-for-service model, I think your point is very well taken. It's very difficult to justify, routine use on every single case, especially now in its current state that there's not extra reimbursement. However, as soon as you pivot over to either a shared savings model or to a capitated model, there is tremendous benefit that is seen in this technology. And some of the preliminary data that we've looked at so far, the number needed to treat to avoid a reintervention is just under 2.5, which is a very, very, very low number to achieve that benefit. And for any shared savings model where you're looking to lower the rates of reinterventions, which are always going to be much more expensive than the cost of a drug-coated balloon, you will see savings very early on, as early as the first year. And as you start to look at the savings across large cohorts of patients, which is typically seen in shared savings models, certainly in capitated models, you can see hundreds of thousands of dollars, if not millions of dollars, seen very, very early on, certainly by year one and easily by year two. Our group took a somewhat pie-in-the-sky analysis and looked at the entire CMS end-stage renal disease population from just a few years ago, looking at the number of dialysis access maintenance procedures. And we speculated that if only 50% of dialysis maintenance procedures used a drug-coated balloon, that in 1 year CMS would save upwards of $400 million. So the savings from the payer perspective can be staggering, but again, it really depends right now on where you're practicing and what your business model is. I hope that that's helpful.
I think it is. I think, one of the things that I've seen over the years is that fee-for-service certainly inhibits the adoption of some phenomenal strategies and technologies that really help dialysis patients avoid the frequent reinterventions. Unfortunately, a fee-for-service model looks for maybe the least expensive and perhaps the least effective ways of taking care of patients so that they come back time and again. But, there is a transition, and there's certainly other payment systems and schemes that may favor adoption of technology to a much broader scope. So I think with that, I think it's time to wrap up the session. I would like to extend my great admiration for wonderful presentations, compelling data regarding the use of drug-coated balloons and AV access. We've covered everything from the most practical aspects of how to use this to the data that's been generated by all of the different studies, including the IN.PACT AV trial, and also some of the discussions on mortality associated with the Paclitaxel, where we just don't see any signal at all for the most recent analyses that's been done. And it seems like this will liberalize in many people's minds the use of AV drug-coated balloons. So with that said, we'll sign off. Thank you very much, both of you.
Thanks very much, Bart.
Thank you.